Hi again, and welcome to week 2 of 8 Beats to Better Outcomes. This week we are looking at a change being made to the overall classification of CTGs and the appropriate management based upon that classification. So instead of normal, suspicious and pathological classifications, suspicious will now be divided into 2 parts. These 2 parts will be suspicious with no other concerning risk factors, or suspicious with additional intrapartum risk factors. So why is this changing? Well, as we might already know, the new NICE guidance is moving away from interpreting and managing CTGs based on the fetal heart pattern alone and is taking more consideration of the whole clinical picture. This includes thinking more about the risk factors that have the potential to impact on how the baby copes with labour. So in terms of features, we know that amber features, one of which would make the CTG suspicious overall, include increased contraction frequency, increased baseline, reduced or increased variability for short periods of time, and also variable decelerations with concerning characteristics. But not all babies will cope with labour in the same way, and these CTG changes must be considered as part of the bigger picture to assess whether this is a baby that's compensating and has lots of reserves, or whether this is a baby that is starting to struggle and needs help. So what's the difference between these subdivisions in this category of suspicious? Well, it's all about how we recognise and treat the cause of the suspicious CTG. For the suspicious CTG with no additional risk factors, the baby is considered to be well built for the stress of labour. The focus is on assessing the whole clinical picture, recognising that if accelerations are present, that this is strongly suggestive that the baby is not acidotic, and using appropriate conservative measures to improve the environment to ensure baby continues to compensate. The management of a suspicious CTG with additional risk factors focuses not only on a full clinical review and using appropriate conservative measures, but also on considering a test of fetal well-being in the form of fetal scalp stimulation and, if necessary, considering expediting birth. This is because for the babies where there are additional risk factors, there is the increased risk that they will move from being a baby that is compensating and coping with labour to a baby that is beginning to decompensate and needs to be delivered to prevent acidosis and poor outcomes. If a baby responds well to the fetal scalp stimulation, it is strongly suggestive that despite the risk factors and the CTG changes, the baby still has reserves, and continuing labour under close observation is a safe management plan at this time. So, by considering the presence or absence of additional risk factors, we can better assess how well the baby is coping and think more about appropriate management for this particular baby, rather than using that one-size-fits-all approach, which may lead to over-intervention or missed opportunities for helping a baby that is struggling. However, to do this, we must have a clear understanding of what those additional risk factors are. So we need to perform a full set of maternal observations and a palpation of uterine activity. A review of labour progress and liquor colour must be undertaken, and pre-existing antenatal and intrapartum risk factors must be considered as part of the discussion and review to ensure that the appropriate management plan is made. We will discuss management such as conservative measures and fetal scalp stimulation and the rationale for their use in the coming weeks. We'll also go into further detail about different features of the CTG, such as baseline and decelerations, that we will be seeing some changes coming in on the new guidelines regarding those. But for this week, it's all about that whole clinical picture, putting the CTG into context to understand how the baby is coping and how we can help this baby in this situation.